Welcome back to part 2, what's really dividing the obesity conversation. In this video, I'm going to talk about the second claim out of the 4 that I was discussing as the fault lines in the obesity conversation. And as a reminder, we're looking at this using the Steelman process, which is presenting the strongest, most logical version of an argument. So, is obesity behaviorally modifiable? Here's some real examples from fat activists. Dieting doesn't work. 95% of people gain the weight back. Bodies have a set point and always return to it. You can't control your weight any more than your height. If weight loss worked, no one would be fat. It's not a personal failure to stay fat, it's biology. The idea that fat people can become thin if they just try hard enough is fatphobic. So the Steelman version of this. Long-term weight loss is difficult. Fat activists would say basically impossible. Many people encounter biological and environmental factors that make sustained weight change extremely challenging. And many people, in fact, do gain weight after having lost it. Repeated dieting can have negative mental health effects, and weight cycling may carry its own physical health risks. The best path forward is to focus on health behaviors like movement, nutrition, sleep, and managing stress rather than weight itself. Weight loss is hard, but it's not impossible. The argument goes too far in suggesting that no one can lose weight long term or that any effort to do so is inherently damaging, disordered, or doomed to fail. Success rates may be modest, but people can successfully lose weight and keep it off, especially with behaviorally informed, structured, supported, sustainable approaches. Framing weight loss as impossible removes agency and may discourage people who want to lose weight for legitimate personal or medical reasons. It is true that dieting and weight cycling can have negative impacts on mental and physical health in varying ways, but with the correct strategies and support, those negative impacts can be mitigated or eliminated altogether. The behavioral model of health intervention has a lot of positives to it, but it is important to acknowledge that reducing body size and mass can have positive impacts on those behaviors or make it easier to engage in health promoting behaviors in the first place. Conversely, stigmatizing weight loss efforts, whether through discouraging them entirely or implying they are insufficient unless perfect, can reduce motivation and infringe on what would otherwise be someone's personal autonomy to pursue health on their own terms. First, let's look at some sources that might be cited by fat activists to bolster the claim that weight loss is impossible or dangerous. So, this study here from 1959, The Results of Treatment for Obesity, a review of the literature and report of a series. This study looked at the routine treatment of 100 obese persons in the nutrition clinic of the New York hospital. This is, as far as I could determine, the source of the often repeated claim that 95 to 98% of diets fail. It was a really limited study from 1959 that looked at just 100 subjects. This is not a high quality source to continue repeating a generalized statistic from. How effective are traditional dietary and exercise interventions for weight loss? Published 1999. Abstract reads in part, although long-term follow-up data are meager, the data that do exist suggest almost complete relapse after 3 to 5 years. The paucity of data provided by the weight loss industry has been inadequate or inconclusive. So, this 1999 review found that diet and exercise programs produce significant short-term weight loss, around 24 pounds on average, with more than half maintained after a year. But by 3 to 5 years, most people regain the weight. Some would use this to argue that weight loss is impossible to maintain. But the real takeaway might be that traditional diets, as they've been practiced, are poorly designed for long-term success. Programs that end after 15 weeks with no support or behavior change maintenance aren't likely to work. That's not proof that weight loss is unachievable. It's proof that we need better strategies and support if we want long-term change. Weight loss attempts and risk of major weight gain, a prospective study in Finnish adults, published 1999. Reads in part, weight loss attempts may be associated with subsequent major weight gain, even when several potential confounders are controlled for. Some research has found that people who attempt to lose weight are more likely to gain weight long term, but the strongest of these studies, like this one on Finnish twins, suggests this may be because of shared genetic or familial traits that make weight gain more likely in the first place. So it's not clear that dieting itself causes weight gain, only that people who are more likely to struggle with weight may also be more likely to try dieting. Obesity and set point theory. This paper says in part, notably, the rate at which one regains weight following weight loss is considerably high, with over 80% of individuals eventually regaining the weight they lost. The set point theory may explain the high incidence of regained weight. Part of the reason I wanted to include this is that it's a paper that reviewed the factors that support the set point theory, which is a theory that bodies will always return to a specific, quote, set point weight, regardless of attempts to diet long term. However, this study also notes some factors that can alter the set point, including things like pregnancy, say, suggesting that this point isn't necessarily set in stone, and if we could figure out the mechanisms that change the set point, then we might be able to change the set point of obese individuals to something lower via structured interventions. Is there evidence for a set point that regulates human body weight? Published 2010. Reads in part, quote, there is evidence for the idea that there is a biological active control of body weight at a given set point. This is another paper that talks about set point theory. It suggests that regular normal weight regulation methods may be, quote, lost or camouflaged by Western diets, unquote, meaning that the failure of biological control may lie in external factors. So, in other words, that the food environment we live in large part, could be affecting the fact that our bodies are not as able to keep to the natural set point. Weight cycling and high-density lipoprotein cholesterol in women. Evidence of an adverse effect. Published in the year 2000. Reads, in part, weight cycling is associated with lower HDL-C in women of a magnitude that is known to be associated with an increased risk of cardiac events as demonstrated in prior clinical trials. So this is the first of a few studies we'll look at that suggest a strong association between weight cycling, that is to say, losing and gaining, yo-yo dieting, in other words, and various negative health outcomes. This one looks at blood cholesterol. Variability of body weight and health outcomes in the Framingham population, published 1991, reads in part, fluctuations in body weight may have negative health consequences independent of obesity and the trend of body weight over time. And this is considered one of the gold standard studies, as it were. It's a longitudinal study with 32-year follow-up data. It shows a clear correlation between weight cycling and negative health outcomes. This is known as the Framingham study, which I'm partly mentioning because it'll come up again later. And here are some theories on why weight cycling can be so dangerous. As far as I'm aware or could find, there were not conclusive answers yet, but here are some solid examples. Metabolic and hormonal disruption. Repeated dieting and regaining can alter insulin sensitivity, leptin, ghrelin, and thyroid hormone regulation, making metabolism less efficient over time. This can promote fat accumulation, particularly visceral fat, which is more strongly linked to heart disease. Some evidence suggests that weight cycling can reduce lean body mass with each cycle, making subsequent gains more fat heavy. And as we have already seen, excess adiposity is associated with low-grade inflammation. Cardiovascular stress. Fluctuating weight may lead to blood pressure instability, lipid volatility, and arterial stiffness, which are harmful to cardiovascular function. The Framingham study found the effects independent of BMI, suggesting variability itself may damage vascular health, possibly through inflammation or endothelial stress. So that means that even if people were not obese, that yo-yo dieting, even among the normal BMI levels, can still be dangerous. Chronic inflammation. Weight cycling may elevate C-reactive protein and other inflammatory markers. The inflammatory response can worsen atherosclerosis, that is, plaque buildup in arteries, and is a known contributor to metabolic syndrome and heart disease. Inflammation may also affect gut microbiota, which has downstream impacts on immunity and metabolism. Psychological and behavioral stress. Cycles of dieting and regaining can lead to shame, disordered eating patterns, and depressive symptoms, which are themselves risk factors for chronic disease and mortality. There may be allostatic load, the quote wear and tear of chronic physiological stress, which affects multiple organ systems and immune response, and loss of muscle mass and frailty. Weight loss often includes some muscle loss. If weight is regained without muscle, body composition shifts toward higher fat to lean mass ratio even at the same weight. Over time, this may reduce resilience, especially in older adults, increasing risks of frailty and functional decline. So essentially, weight cycling, not a good thing. Here also, the association between weight fluctuation and mortality results from a population-based cohort study published in 2005. Reads in part, weight fluctuation is associated with a higher risk of all-cause and cardiovascular disease mortality in the U.S. population, even after adjustment for pre-existing disease, initial BMI, and the exclusion of those in poor health or incapacitated. So this study confirms the results of the 1991 Framingham study with a different data set, and they were specific in the abstract that they talked about adjustment for certain other conditions. So that means this is a very strong study. Associations of short-term weight changes and weight cycling with incidence of essential hypertension in the EPIC Potsdam study, published 2005. Abstract reads in part, the effect seen for weight cycling supports the hypothesis that weight cycling increases the risk of hypertension. Again, pretty self-explanatory. In particular interest, this study showed that the risk of hypertension was greater for those who experienced weight cycling than those who experienced consistent weight gain. Low-calorie dieting increases cortisol, published 2010. Reads in part, restricting calories increased the total output of cortisol, and monitoring calories increased perceived stress. So this is a pretty small study, and it does show minor increases in cortisol with a fairly low-calorie diet. This diet here was 1,200 calories a day, which is pretty much at the lowest level you are supposed to have for a non-medically supervised diet. So it doesn't necessarily mean weight gain. That is to say, increases in cortisol. Long-term elevated cortisol rates can increase factors that lead to weight gain. For example, increased hunger, slower metabolism, but a caloric deficit will still result in weight loss. At the end of a diet, cortisol levels should equalize, but a person who's switching from diet calories to maintenance level calories might experience a small bump in weight gain as their body stabilizes. This is really normal, but it can freak people out. Body weight loss increases plasma and adipose tissue concentrations of potentially toxic pollutants in obese individuals. So this study is actually really interesting, I think. It says here, organic chlorine pollutants were found in every subject, and all 19 compounds detected had their plasma concentration increased following treatment, which is to say a mean body weight loss, 15 of which were statistically significant. When compared with a control group, 5 compounds increased significantly. Essentially, this is a rare but biologically plausible complication of weight loss that is often omitted from popular discourse. Organochlorines are toxic compounds that accumulate in fat tissues over time. When fat is lost, these compounds enter the bloodstream and can affect endocrine, immune, reproductive, or neurological health. It doesn't outweigh the benefits of weight loss for most people, but it's a good reminder that weight loss should be approached with medical supervision and individual context in mind. There are obese patients who would be especially sensitive to these compounds, and a doctor should be aware of their weight loss and watching out for these potential sensitivities. Obesity stigma, important considerations for public health, published 2010. Abstract reads in part, quote, rather stigmatization of obese individuals threatens health generates health disparities, and interferes with effective obesity intervention efforts. Some argue that the risks associated with weight loss aren't just physiological, but also social. For example, the stigma people face when attempting to lose weight, especially when they don't succeed quickly, can create stress, shame, and avoidance behaviors that actually undermine success. Both in terms of weight loss and health promoting behaviors like eating nutritiously or engaging in exercise and stress reduction efforts. So, this is pointing out something that fat activists say often: stigma is a big problem, and it is. And now we'll look at some sources supporting the idea that obesity is behaviorally modifiable, which is to say, weight loss is achievable, and science says so. First of all, this is the article from the New York Times that talks about the 95% of people regain their lost weight statistic, and they point out that the number was first suggested in the 1959 clinical study of only 100 people. But what one professor says here, quote, that 95% figure has become clinical lore. There's no basis for it, but everybody says it anyway. Long-term weight loss maintenance, published 2005. Abstract reads in part, quote, research has shown that approximately 20% of overweight individuals are successful at long-term weight loss when defined as losing at least 10% of initial body weight and maintaining the loss for at least 1 year. So, weight loss is possible. This particular paper was written to discuss the findings of the National Weight Loss Control Registry, which we'll talk about just a little bit later. 20% may not seem like a huge success rate, but it, even for 2005, it's a damn sight better than 95% failure. Long-term weight loss maintenance, a meta-analysis of U.S. studies, published 2001. Conclusion reads in part, 5 years after completing structured weight loss programs, the average individual maintained a weight loss of over 3 kilograms and a reduced weight of more than 3% of initial body weight. So the average losses maintained were pretty modest, but statistically significant. What was additionally interesting is that they said after weight loss of more than 20 kilograms, I wrote pounds, but it clearly says kilograms, individuals maintained significantly more weight loss than those who lost fewer than 10 kilograms. And this makes total sense to me because it takes longer and requires more behavioral change to lose 20 kilograms. So when you've reached the point at which you have lost that much weight, you have already created the habits and habit patterns and behavioral patterns necessary to continue your weight loss and maintenance. This is findings from the National Weight Control Registry itself. The National Weight Control Registry was established in 1994 by Rena Wing from Brown Medical School and James Hill from the University of Colorado. It's the largest prospective investigation of long-term successful weight loss maintenance. Given the prevailing belief that few individuals succeed at long-term weight loss, the NWCR was developed to identify and investigate the characteristics of individuals who have succeeded at long-term weight loss. The registry is tracking over 10,000 individuals who have lost significant amounts of weight and kept it off for long periods of time. Detailed questionnaires and annual follow-up surveys are used to examine the behavioral and psychological characteristics of weight maintainers, as well as the strategies they use to maintain their weight losses. They have released some of their findings on their website. I think there's a whole lot more information that you can get if you have professional access to their registry, I think, but I was not able to find more information. Needless to say, the information that they do provide to the public is pretty good. Registry members have lost an average of 66 pounds and kept it off for an average of 5.5 years. Some lost the weight rapidly, others have lost the weight very slowly over as many as 14 years. 45% of registry participants lost the weight on their own, and 55% lost weight with the help of some type of program. 98% of registry participants report that they modified their food intake in some way to lose weight. 94% increased their physical activity, with the most frequently reported form of activity being walking. Most reported that they continue to maintain a low-calorie, low-fat diet and high levels of activity. Importantly, 90% of registry members exercise on average about 1 hour per day. And again, the most frequently reported form of activity is walking. This shows that weight loss is achievable and it's pretty simple, not easy, but simple. Attempting to lose weight, specific practices among US adults, published in 2004. Abstract reads in part, among those trying to lose weight, the most common strategies were eating fewer calories, eating less fat, and exercising more. Only 1/3 of all those trying to lose weight reported both eating fewer calories and exercising more. So, some critics argue that diets don't work and that behavior change can't produce lasting weight loss. But this was a national survey of over 30,000 US adults, and it found that only 1/3 of people trying to lose weight were using the two most effective methods in combination, eating fewer calories, exercising more. So when we look at studies claiming that diets don't work, we should be asking, were people actually following evidence-based methods? If they weren't in a consistent calorie deficit, then of course weight loss didn't happen. That's not a failure of biology, it's a problem of implementation. So it's important to remember that as of 2004 at least, many people were probably not engaging in the combination of behaviors they needed to lose weight successfully. That doesn't mean that they couldn't lose weight, it just means that they didn't. The Diabetes Prevention Program, Description of Lifestyle Intervention. This paper provided, quote, a detailed description of the highly successful lifestyle intervention administered to over 1,000 participants. This here, one of its goals was to reduce weight and maintain a weight loss of 7%. What I found particularly interesting about this, in addition to the little list of features that the methods used did, which was individual management, lots of contact, behavior and self-management curriculum, flexible maintenance intervention, combining group and individual approaches, toolbox of strategies, tailoring of materials and strategies. All of this seems really important. But what I also found really interesting was that this lifestyle intervention was compared with metformin, which is a pretty common, quote, last line medication for weight loss for people who have diabetes. And this abstract said that the lifestyle intervention itself decreased the incidence of type 2 diabetes by 58% in comparison with the metformin treated group, which decreased the incidence of type 2 diabetes by only 31%. So that's pretty cool. USPSTF recommends intensive behavioral intervention for obesity. The task force found that intensive multi-component behavioral programs are safe and effective, can help patients lose and maintain weight loss, and reduce risk of diabetes in people with elevated glucose levels. So the USPSTF is the United States Preventative Services Task Force. It's a public health platform that makes evidence-based recommendations for preventative medicine, meaning that their experts reviewed studies and various behavioral programs and found them worthy of recommendation on a national level. Prospective study of intentional weight loss and mortality in never smoking overweight U.S. white women aged 40 to 64 years, published 1995. Abstract reads in part, in women with obesity-related health conditions, intentional weight loss of any amount was associated with a 20% reduction in all-cause mortality, primarily due to reduction in mortality from obesity-related cancers. So this study of 40,000 women showed that intentional weight loss of any amount reduced mortality rates in women who had obesity-related conditions. Apparently, weight loss made little difference in women who were otherwise healthy. suggesting that the benefits are greatest when health is at stake due to comorbidities. However, it doesn't mean weight loss is useless. It just means the benefits are clearest, and that when health is already at stake, and that not all weight loss is equally meaningful. Well-being and morbid obesity in women, a controlled therapy evaluation. Abstract reads in part. Women in both active treatment groups lost significant amounts of weight, while members of the control group showed a non-significant increase in weight. At 6-month follow-up, treatment benefits were maintained. So this study is also, again, super interesting because it was actually a clinical trial studying the impact of cognitive treatment and behavioral treatment on obese women. So the women were split into 3 groups: cognitive group treatment program and a behavior therapy weight loss program, or the control group. And they found that both treatment groups resulted in weight loss, even though weight loss was not the primary focus of the trial in and of itself. The trial was mostly to look at how it helped their psychosocial coping, depression, anxiety, eating related psychopathology. But this does suggest that therapeutic modalities may be as important, or maybe even more important, than traditional weight loss strategies in education, because in this case, they weren't necessarily aiming directly at weight loss, and yet these women still lost weight. Overall, these studies they prove, in my opinion, that that obesity is in fact modifiable via behavior. It's certainly not easy, but I think what these studies show is that over time, as we're getting more granular and scientific about exactly what things work, we're finding that programs that focus on mental health, focus on behavior change, that are modifiable for individual humans and their individual needs, are creating a lot more success than just simply throwing out the advice to eat less and move more, which it's not that that's untrue. Eat less and move more is the core, but there are so many ways to eat less and move more, and they're not all equal. They don't all work for every person, and there are actually a lot of roadblocks that are in our way, from our biology, our genetics, which are components, to societal influences, marketing. So many factors go into why we are the size that we are. And even though calorie reduction, or calorie deficit, I should say, is the way to lose weight, how you get there can really happen via any number of paths. And increasingly, studies are showing that a more holistic, differentiated way of making weight loss programs is the way forward. But the upshot is, it's definitely possible. Don't let anyone tell you it's not. Thanks for watching, and in part 3 of this series, we will look at obesity's social consequences, and the juxtaposition of that with bodily autonomy.